Asasiya, Midwife. Asasiya, welcome back. I never knew TV, right?
Thank you.
All right. First question we want to get into is can you please explain what postpartum is and why it's such a difficult period for women?
Yeah. Well, postpartum, just post meaning after partum, giving birth, is just the period after a mom has given birth. And so that can be, there's an immediate postpartum. So that's right after you give birth. That's the immediate postpartum. And we would say that's like the first 6 to 24 hours, depending on what's going on. And then the longer postpartum period is 2 to 3 months, like 6 weeks by standard. So some people use postpartum as a short way to say postpartum depression. So I actually wanted to clarify with you if you meant postpartum as in postpartum depression or the period of postpartum.
Postpartum and postpartum depression.
Right. So for the first 2 to 3 months after someone has given birth, their hormones are adjusting to back to like their pre-pregnancy state. And so there's a drop in estrogen and progesterone, like a sudden drop in that. And so it can throw off your moods. There's something called baby blues, which affects about 70% of women, right? It's just like you feel a little bit of grief. You might feel weepy. Sometimes it even makes you a little bit disconnected from the baby, but it doesn't go to a dark place. And usually with like sunlight, magnesium, more sleep, that resolves on its own after about 2 weeks. Postpartum depression is when that takes a turn, or if it goes on longer than 2 weeks, and then you have, like depressive symptoms, like you can't get out of bed, you don't want to connect with the baby, you don't really want to take care of yourself, you feel sad, and it's kind of inexplicable. So that's a combination of the hormones and then probably also other conditions that's going on right in your life. It could be that you weren't really prepared for the pregnancy or you don't have the type of support. But most commonly it is because you're probably tired, you're using a lot of sleep, and that just affects you overall. That affects about 10% of people, postpartum depression. And then beyond that, there's something called postpartum psychosis. So a lot of times in the news, you might see a story where it looks like a mom just went crazy, or like, why would she do that to her children? Particularly us, like Black women, when you see something that seems erratic, we're like, our first instinct is, wow, this person is a monster, but not realizing like she could be going through some mental issue right now, like that stress. And because it's so stigmatized in our community, people just take it as like, I'm in a bad mood, or da da da. Like there's no rationale for it, when in fact, like, she's stressed beyond what she can manage, or that person is stressed beyond what they can manage.
There's one thing I want you to touch on before we go to the second part. Dealing with distress. I've learned this as a man, and this applies to women. We don't have the tools to deal with stress.
Right. One of the things that I think is the biggest problem that we face in our society, which is different than maybe like our grandparents, is that we have moved away from our families. So we used to be in communities where like our grandmother would watch the children, or our mother would watch the children. We have aunts and uncles and cousins, and we're just part of like this village of immediate family. And now, like with the cities, like us moving to cities like, like New York and Philadelphia, and just away, like going to college or whatever it is, we tend to not have that family support when we're starting families. And so the stress, starts to mount on the mom and then the dad, and then they're both stressed out together, and we don't have healthy coping mechanisms because we don't have a good village.
All right. Well, what can women do to get through this postpartum period, and how can men support women to get through this postpartum period?
Yeah. So one thing is, I always go back to nutrition. Like what you're putting in your mouth has a lot to do with it. So just making sure that you're nourishing yourself well, because if you're breastfeeding, or even if you're not breastfeeding, like having lost all those nutrients, or sharing those nutrients with your baby, starts to deplete you, particularly of things like vitamin D and vitamin B, which can stabilize your mood, and magnesium. And there are herbs like motherwort that can help you to balance your hormones a little bit better, deal with that period more gracefully. Getting sleep is a big big thing, because like sleep deprivation, whether you have a baby or not, can start to make you feel a little loopy. So getting a lot of sleep is important. And it's hard when your baby is up through the night and you're trying to nurse or you're trying to feed. So dad could play a big role in that, in sharing some of that load of, like, whether it's pumping, putting milk aside so that dad can feed the baby, or preparing a bottle, which I don't necessarily advocate formula feeding too much, but that, breastfeeding is not a reality for everybody. And one thing that people don't realize is that men also have postpartum depression sometimes, because when a man has a child, his testosterone drops. Like almost the moment that the baby is born, his testosterone drops because it allows him to bond with the baby. Like, you can, like, testosterone is what makes men aggressive.
Babies tone you down, yeah. That's
yeah,
real. Yeah,
especially if you're a girl dad, right? But
Tone
whatever the baby is a baby. Your testosterone drops, and if you're not in touch with that, like if you're not connected to that, then it can manifest as irritability, indecisiveness. I know that I've experienced that too with, my partner. When we first had a child, like, it seemed like his mood was changing, but it's that drop in testosterone, the mood changes that come with that, and then also just the life circumstances. So a man might feel overwhelmed with that drop in testosterone, those mood changes, and then you accompany that with like lack of preparedness for the baby, and then you start to see like fatherlessness. Not saying that is the sole reason, but that can contribute to why men leave. He went to get milk and he never came back. He was stressed out too. So it's something that we have to hold the mom and hold the dad together as a unit.
Can you tell us, what is a OBGYN, known as obstetrician and gynecologist?
That's what it is. So an obstetrician is one field and a gynecologist is another. An obstetrician is a doctor who is trained to manage and treat pregnancy and labor and delivery. And a gynecologist specializes in the female reproductive system. So gynecologists don't necessarily deliver babies. But if you're an OBGYN, likely you do both, right? And that is someone who, they can manage high risk. They can manage most high risk pregnancies. They care for people when they're pregnant. They do the assessments. When you go to the doctor, they interpret the ultrasounds a lot of times and the lab work, and they see you in pregnancy and they deliver your baby. Obstetricians are also not gynecologists, but obstetricians are trained in surgical procedures related to pregnancy. So they can do episiotomies, which is, midwives can do episiotomies too, but they namely do C-sections. So that is their specialty as surgeons. Distinct from perinatologists, right? So perinatologists are doctors who specialize in high risk. So they're obstetricians who have additional training in high risk pregnancies. So if you have, let's say you had diabetes or you had hypertension already or a kidney issue and you became pregnant, an obstetrician you can work with and they will ultimately deliver your baby. But maternal fetal medicine, aka a perinatologist, is the one who's going to interpret all of your information and give you the best course for monitoring the pregnancy.
I want to ask you something real quick, right? With this blood pressure with the pregnancy, is it because of like the stress of the pregnancy, or is it always the diet? I hear people always talking about this diet, but is it just like it's such a stressful situation why women's blood pressure rise when they're pregnant?
Yes. So stress can definitely contribute to elevated blood pressure, right? The way I think about it is like your blood pressure can be high for physiological reasons and it can be high for pathological reasons. If it's physiological, like my blood pressure right now, if you take it, it could be higher than normal if I'm nervous, or if I just had a very salty breakfast, or if I didn't sleep well last night. You check my blood pressure, it's going to be high. But then if I change certain conditions, like I get some sleep, I drink some water, I change something else that I'm doing, then my blood pressure will normalize. So we'll say that's like a physiological issue, right? And the same thing can happen in pregnancy where you have like physiologically high blood pressure. It's pathological when it goes beyond a certain point. Like it's even higher than what we would think is high blood pressure. And things that you're doing can't change it. Like there isn't really like a lifestyle change that you can make to address it. And so that could be a result of like how the pregnancy is taxing your immune system and affecting your cardiovascular system, and could develop into preeclampsia or just gestational hypertension.
All right. And I want to jump back into it now. Can you tell us how does the care provided by an OBGYN differ from the care provided by a midwife?
Yeah, so a midwife is an expert in low risk or normal pregnancy. We're experts in the routine, understanding that pregnancy is a normal physiological condition under most circumstances. It's not a medical condition that requires a doctor all the time. And so an obstetrician, even the most well-meaning obstetricians, are limited because of the volume of people that they work with to be like this personal type of provider. So some people will say like, oh, I love my OB. They're very nice, but they don't often spend much time with their patients. They're really concerned with the numbers, like, well, what is your blood pressure today? Listen to the baby. Okay, great. And then they'll see you again and then give you a recommendation and give you a prescription. Whereas a midwife, we're interested in all of those same things, obviously, for your safety and health, but we're also interested in you as a full person. So we're more holistic. We're looking at like, well, what's going on at home, and what's going on with your other children, and what's your relationship like with your mom, and what did you eat today, and what are you going to eat tomorrow? That kind of thing. We're really interested in the full experience of pregnancy.
And can you also touch on this idea that's circulating that home births, or should I say hospital births, are safer than home births?
Sometimes hospital births are safer than home births. So I have to say that it's the issue is not always that hospital births are a problem in and of itself, because the hospital can be, if you have hypertension or if you have preeclampsia or if you have diabetes, then you should be in the hospital, because the hospital has the technology to deal with a situation that's risky. The problem is what happens when you're in the hospital that makes people feel uncomfortable. It's like not being seen or just being treated as someone who's pregnant with hypertension, and not like having a name and having other concerns and fears and wanting to be seen and heard. But if you're healthy, then the hospital is not necessarily safer, because I think of it as having a cold and then someone treating you like you have pneumonia. So a cold, you might drink some tea, get some rest, drink some water, and everything is good. That's like working with a midwife. But if someone starts to give you antibiotics and then they start to pump your lungs, and it's like, wait a second, something that was actually very treatable and normal, you pathologized and made it worse. And so in that instance, hospitals can be unsafe for healthy pregnancies and deliveries. Yeah, so in terms of like the safety of home births, if you're working with a midwife who is trained, it's important to know that you don't just call a midwife and she shows up to the house and delivers the baby. There's a process of monitoring the labor itself. So we listen to the baby in labor the same way the babies are listened to in the hospital. We assess your vitals in labor, and we always have a metric to determine that it's still safe to be at home. So in that sense, home birth is not unsafe if you're with a skilled provider.
And what things do you look for to kind of gauge the point where they probably should go to the hospital?
Yeah, so we are protocol driven. So normalcy is measured by quantitative data and qualitative data. So let's just say quantitative for now, like the numbers, like the blood pressure numbers match into this range of what we consider normal. Does your pulse match into this range of what we consider normal? Does your baby's heart tones match into the range of what we consider normal? Are you doing things that you should be doing? Like, are you able to walk to the bathroom and eliminate, that kind of thing? So as long as we are seeing that this is all normal and everything we're monitoring falls into the spectrum of normalcy, then we say, okay, this is safe. We're experts in this. We know how to manage it, even if a normal complication were to arise. When something drifts outside of that, and we can't resolve it through like those physiological means, then we would say, well, this is now going into a riskier category than what we would be able to manage at home with the tools that we have. And that's when we would consider a transfer of care back to the hospital. And even in those instances, most midwives will accompany, they'll stay with you there at the hospital to continue to advocate for you and help you understand like what this change means, and what you can expect to unfold, what interventions are necessary, and which ones we can kind of negotiate.
People seem to be unaware how developed the baby is at the 15th week mark. Can you tell us how developed the baby is at the 15th week mark?
Yeah. So, well, I'll say this. By 12 weeks, if someone starts care with me, I can hear the baby's heart tones, and the baby is living somewhere right above the pubic bone. At 15 weeks, the baby is about the size of an apple. About what's that? Yeah. And, they have ears and eyes. The eyes are still fused shut, but they have fingers. They obviously have a head, a spine. You could even see their sex organs on an ultrasound. Not in all cases, but in lots of cases. They can respond to light, though they can't like necessarily open their eyes, but they can they might move around if you put light on your abdomen. So yeah, they're a little being at that time.
Please share why it's so important for the father to be present at the hospital during the entire labor to protect the mother from being pressured to do things that don't necessarily need to be done.
Well, that's kind of a leading question, because that is assuming that the father knows what doesn't need to be done or what needs to be done. But I will say that the father's presence, not even just in the labor, but throughout the pregnancy, can lower the mom's stress. It can also help to mitigate negative behaviors. Like there have been some studies that show that a woman has like a 30 to 40% chance of quitting, like let's say smoking, if the father is present. And so in the instance of, or even at like hospital visits or doctor's visits, if the father is present at the visits, the encounter is a lot different. Different kinds of assumptions are being made. A different level of respect might be given if the father is physically present during those visits. So the same thing transfers over into labor. It's important for the father to be there, not to be combative necessarily, but to be like, he should have already informed himself about certain things, what to expect, and then to be there as an intermediary for the consent process. So something that I've seen like two extremes. I've seen one extreme is the father goes in and he kind of becomes a fly on the wall, where he thinks like he's no longer part of this process anymore. And it's not because he doesn't want to be, but because the doctors and the staff take such an authoritative position that he loses sight of what his role is. And so, and then on the other extreme, you have a father who's very combative, like, maybe speaks for the mom and like answers questions for her without giving her the proper space to consider it for herself, or even talking about it with her. So I think a good place for the father to be, and a useful place for him to be, is kind of creating space. So like if a doctor comes in the room and a suggestion is made, maybe he could say, I would like, my wife and I, or my girlfriend and I would like a second to talk about it, and then you can come back in. And he can assert himself in that way, and then maybe call on the doula or call on some other person that or do some research, and then kind of help make those decisions. But just to be combative or to take a step back, neither of those are really functional in that moment.
All right. So what are some things men need to know prior to going to the hospital when their lady's in labor?
I mean, it's good to have a birth plan, right? So I think it's good to think about what your values are ahead of time, and then have those written out, and understanding what the health condition that your wife is in, and then either consulting with a doula or the midwife, or doing your own private research as to what are some common interventions when someone is dealing with this condition. So if she's healthy and you know that she's healthy, then you can push back against interventions that might say, let's speed up this labor. Like they might come in and say, let's do Pitocin, because that is a common intervention. That's a very common intervention, especially if you go into the hospital very early in labor. They're looking at like, we're not trying to be in here all day, especially if they don't send you home. So you can kind of push back on things like that, like, oh, let's, can we get a ball? Can she walk around a little bit? Thinking of different kinds of measures to keep her comfortable in the hospital. So reading, learning massage techniques. I would say even encouraging her and helping her to stay home as long as possible. If you don't have a doula who can also help with that, the doulas can help the dads be more supportive. But knowing what those interventions are going to be is important, but you have to know what your wife's or your girlfriend's health status is first to know what really you should expect, and then having a birth plan.
All right. And the second part is what should men expect during and after the pregnancy?
During and after the pregnancy, or during after the birth?
During and after the birth.
During and after the birth, you can expect that she's going to want you more than anybody else. She's going to want you. Even if you guys were not on great terms, she's going to want you, and she wants you to be nice to her, and she wants reassurance from you. So that's what you can expect, is her seeking you for reassurance. She's going to want to hear kind words from you, like, you're doing amazing, you're so beautiful. Women sometimes feel self-conscious in labor about making noise or how they look, and so giving her those sweet words helps to produce oxytocin in her body. And we may have talked about it before, that oxytocin is that love hormone, it's that bonding hormone, and it's also the real form of pitocin that helps labor to progress. So if you're kissing her and rubbing her forehead and like pulling her, stroking her hair in a gentle way, rubbing her feet, her hands, her arms. These are all things that you can expect during the process that she's going to want and that you should provide. You can expect that it's going to be a very intense process, and that it's a process that kind of unfolds in increasing levels of intensity. So in the beginning, you might feel like, okay, we could do this. Like, I can give you these nice words and give you some water and tell you to go in the shower. But at some point, it is going to get really intense, and you kind of have to ride those waves with her, make eye contact with her, and reassure her that she can do it. So that's during, and then right after, I mean, you're going to expect to have a baby. What do you mean? You're going to expect her to be exhilarated, but breastfeeding is a thing that you can expect right after. I don't know if I understand your question. What do you mean right after?
Right after, in regards to support again, because the baby comes out, right?
Yeah.
And it's a lot going on because they take the baby away. You just had a baby.
No, they don't always take the baby away. So depending on where you are, like, okay, are we assuming that someone's in the hospital?
In the hospital.
So in the hospital, we can advocate for, and you can ask that the baby comes immediately to mom and comes to mom's chest, and you're right there with them. And even if the baby needs to be taken away to like the NICU because there's a complication, you can go follow the team and see what's going on.
Hold on. Can you explain? No.
Sorry.
Can you explain what word it needs to be said to make sure the baby goes directly to mom at birth so people know?
It's called immediate skin to skin. In a lot of hospitals, I have to give them credit. I mean, that's like built into what they do now. So it's not like back in the day where they'll take the baby, immediately cut, and then take the baby to the warming station. But they will do that if you don't push back a little bit, especially if it's like a bustling staff and they're just trying to do their job and get out of there. They can kind of miss those significant moments in the sacredness of the experience. So they'll just try to get through it instead of leaving space for immediate skin to skin and for the energy to stay as low as possible. And that's something that dad, doula, whoever can advocate for in that moment, is that you have like a pause, right? Once the baby is born.
What can dads do to make a connection with the baby while the baby is still in the womb?
Talking to the baby. So like putting your mouth where the baby is located and singing song, like even if you sing like the same song over and over again, it could be like a sweet lullaby, or it's like, I'm your dad, or whatever it is, just saying that, like the baby will recognize the vibration of the voice. I've seen babies come out and they hear their dad's voice and they respond to it like automatically. And so talking to the baby, being nice to the mom is a nice way to connect, because you creating that safe and gentle space for her affects even the hormones that are produced in the amniotic fluid that the baby is receiving. So anything that you do that's affirming to her is going to affect your baby positively, which is you connecting with the baby, right? But definitely your voice, touching, being present.
Is there anything else you would recommend
For what?
men can do to get closer to the baby while it's still in the womb?
Besides talking to the baby, I have to think about that. I don't think I prepared for that question very much. But hold on, let me think about that. I mean, what else would someone do to connect with their baby in the womb? I don't know what they would do besides talk to the baby. I mean, you could pray for the baby. I don't know how deep you want to get.
You touched on this before when you were here last time, but can you talk about the importance of the placenta?
Yeah, the placenta is the only organ that your body develops for a limited time and then is only useful for a limited time, and then it kind of expels after the delivery. So that's what it is, that the placenta develops in the uterus as a way to nourish the baby. Like it pulls from the mom's blood to nourish the baby. The interesting thing about the placenta is that I think of it like soil. Like even if you look at it once it comes out, it's very spongy, and it develops round, and it changes according to the health of the mom, even the placenta. So a healthy placenta is round, but if it takes a different shape, or if it is not like this bright red kind of beet color, it develops fatty deposits. All of that is a reflection of what's going on with the mom and can indicate, later conditions for the baby or how the baby was doing in utero. But it's like spongy soil. And so if you think about the placenta as the soil and the child as the tree, interestingly, the placenta also looks like the tree of life, right? But the baby being the tree itself, and then the placenta being the soil, you think about what would you put into soil in order for a tree to grow healthy and strong. So that's one way I think is very helpful to think about the function of the placenta and how important what you eat is to that placenta. Not even just what you eat, but the environments that you're in, right? Because even the soil itself, you could put water in it, but if it's not the right kind of water, if it's not exposed to proper sunlight, it's not going to do much for that tree. That being said, I also found out recently, this is very interesting, that boys take more from the placenta, than girls do. And so it's really important. Like if you find out that you're carrying a boy, even more important. And it's equally important, boy and girl, but because boys rely on it so much, because they want to grow so fast, it's really important to think about what you're eating. In terms of what to do with the placenta once you have it, once it's been delivered. So the hospital, you do have to sign a waiver to get your placenta. Like if you don't want it, fine, they'll take it downstairs to pathology and do whatever they do with it. But a lot of times you might want to take it to do whatever you want to do with it. And culturally, in some traditions, we have planted the placenta. Like in Caribbean cultures, they plant the placenta with a fruit tree, to signify that this baby will never go hungry, because it can always go back to its original source of nutrients to get nutrients. And so if you don't have access to planting a coconut tree or a mango tree or a fruit tree, it's nice to plant it with a tree because it does signify the baby's first home.
Can you explain why breastfeeding is so beneficial to the baby's immune system?
Yeah, because in breast milk, the mom is sharing her antibodies with the baby. And so in layman's terms, antibodies is what your body produces to fight off unwanted substances. It's, so breast milk can help protect you protect the baby from ear infections, digestive issues, understanding that a lot of illnesses start in the gut. If you're giving the baby a healthy start with breast milk, then you're helping to boost its immune system and fight off things that are going on in the external environment through breast milk. But breast milk has lots of other immunological functions, right? in that it also helps to build emotional intelligence and decrease levels of stress for the baby because it's a bonding mechanism as well. So in breastfeeding, you're obviously feeding the baby the best source of nutrients, but you're also bonding with the baby and helping them to develop a strong IQ, build emotional security in the process of nursing.
Um, so I know many women unfortunately can't breastfeed, right?
Hmm.
What is the reason for it, and should they internalize? I hear women like they almost feel bad they can't breastfeed, but it's not really. It doesn't have anything to do with them sometimes, right?
Yeah, sometimes, yeah. I don't think anyone should feel bad if they cannot breastfeed, but some of the barriers to breastfeeding are like the shape of the nipple sometimes can affect breastfeeding. Some people have inverted nipples where it doesn't protrude far enough out for the baby to be able to get the milk from breastfeeding. That doesn't mean that you can't provide breast milk because you could pump breast milk and provide it in a bottle.
Can't latch on.
The baby might not be able to latch on. Sometimes people have a supply issue where they're not producing the amount of breast milk that their baby needs. And that could be because they're not consuming enough nutrients. And so that happens, or it could be like a hormonal issue where their body is just not able to because they're not producing enough of the hormones that they need to produce an adequate supply of milk. And so, and then there's also personal reasons. Like some people have a history of trauma around their breast or like sexual abuse. And so they can't disassociate that from the process of nursing. And so no one should be demonized or vilified for that. But I do think there should be a lot of education about the benefits of breastfeeding and then also seeking the support that you need to overcome the barriers that you can overcome. So working with a lactation consultant or a peer consultant, going to breastfeeding support groups can help. And now you can even do virtual support. So like from the comfort of your own home, like talking to a consultant who can talk to you about positions and other tools.
And if a mother can't generate breast milk, right? Do they have to work with the formula, or is there any other
No.
option?
So there's also human milk banks where if you're open to that kind of thing, where people who do have like a lot of breast milk, they donate it and then it goes through its own like sterilization process so that it's still nutrient, but it's not yeah, but it's also not like, you're not like feeding from somebody else. Like they take it through its process. But you could do human milk banks in lieu of formula.
Why do you believe staff support is so low for women giving birth in a hospital? And how does this lack of support impact the birthing experience of the mom?
Yeah, so staff shortages in the hospital has definitely been an issue with the retiring boomer population. So like our parents, our mothers, our aunts, and maybe some of our uncles who were nurses are now retiring. And so they're leaving the hospitals. And even the people who are new nurses, they're maybe going into higher levels of nursing, like nurse practitioners, and opting to not work in the hospital setting and more like outpatient work or office work. And so they're not choosing to be in the hospital so much. And then COVID contributed a lot to that because people were trying to not be in the hospital if they didn't have to be. So they found other ways to use their nursing degrees, which pushed people out of the hospitals. In addition to the burnout like that people experience during COVID, and if there are shortages, the people who are there are often burnt out. Like they're fatigued, they're working long hours at a time. And so how does that affect the mom? Um, you have a greater chance of medical errors when someone is fatigued. They almost kind of lose sight of what they're actually doing. Like you go on autopilot and you might, choose the wrong medication or something like that. And so when you have that level of like overlooking certain things that could be major because you're tired, then there's more room for error. Not to mention that we are relying more on technology in the hospital setting. For example, I have accompanied people to the hospital who are great candidates for what we call intermittent fetal monitoring. The standard of care in the hospital is something called continuous monitoring. Like, you go into the hospital, the first thing they do is they put 2 straps on, one to measure the contraction, one to measure the baby's heart tones. That is not an evidence-based practice, but if you work in a setting where you have limited staff and you can just strap somebody to a bed and just watch them on a monitor outside the room, then your job is easier. But hospitals should and can allow intermittent monitoring, but that will not happen if the nurse has been there already for 11 hours and she's not trying to come into that room every half hour to listen to your baby. And so they'll say, like, oh no, we can't do that for XYZ reason, when that's not necessarily the case. And so there becomes like a heavier reliance on technology, and there's like this human disconnect in the hospital experience. And then sometimes the lack of continuity of care because of the staff turn around, even with the shift change, right? So you don't see the same person. You have to say the same thing over and over again to protect your birth plan. So I think that's how staff shortages are affecting people. And I want to shout out New Jersey, where we are right now. January 8th, Governor Murphy, with the inspiration and assistance of his wife, First Lady Tammy Murphy, helped to pass legislation that mandated hospitals and birth centers to have a policy that includes doula support. So they have to make it visible now. Yeah, and so now I guess that kind of offsets some of the staff shortage issues, but it also holds more space for the mom to have an advocate on site and saying that we affirm your choice to do that, and we want you to do that, and we encourage you to do that. And so I think that's been really groundbreaking legislation for New Jersey, and I'm hoping that it trickles down to Philadelphia, Pennsylvania.